Good morning, everyone. Thank you very much for attending this morning. I'm pleased to introduce Dr. Autumn Feaster. She is a graduate of the University of Pennsylvania with a PhD and currently serves on the following, serves at the Perelman School of Medicine, University of Pennsylvania. She's the faculty program director for the Penn Master of Bioethics program, founder and director of the Penn Program for Clinical Conflict Management, an education officer at the Department of Medical Ethics and Health Policy. She's also faculty program director, Master of Sciences in Medical Ethics program, associate professor, Department of Medical Ethics and Health Policy, and vice chair for education for the Department of Medical Ethics and Health Policy. She participates in national and international projects and programs and committees regarding medical ethics and conflict management. She has just no other disclosures to confide in, and she's going to talk to us today about the difficult patient, which is always a difficult topic for everyone in terms of knowing the right kind of approach and our responsibilities and liabilities. I'll remind people that please mute your microphone and better turn off your camera too. Also, please post any questions in the chat box and we'll address those at the end of the program. Don't forget to click on the link that'll be posted towards the end of the program in the chat box to review the program and receive credit. And Dr. Feaster also noted to me that about halfway through the program, she will be asking a question expecting an audience response. So I'll monitor those responses in the chat box and I can feed those back to her. So apart from that, we'll get started. So Dr. Feaster, without further ado, take it away.
Great. It is so nice to be here. Thank you so much for having me. So I'm going to talk today about the challenging patient. If we talk about the difficult patient, we put it in quotes because, of course, it's so, it has such a negative bias. So I'll be careful about that. But my approach is to give us some ways of thinking about challenging patients and families that might give you a different way in to working with those dynamics in a constructive way, and a way that might, and I hope ultimately might be more fulfilling for you in terms of the kind of relationships that you build with patients and families. So this presentation is collated from some of the work that I've done. If those papers are of interest to you and you can't access them, don't hesitate to reach out to me. I'm very easy to find, but I can also put my email in the chat at the end, and I can send them to you. Okay, so what are we going to try to do in this short time that we have together? First, I want to show you what the empirical literature says about the difficult patient, about challenging patients and families, because I'm going to challenge that empirical literature. Because from a conflict management perspective, I'm concerned that defining difficult or challenging patients and families the way that we typically do is going to lock us into conflict rather than enable us to try to navigate through conflict. So coming from the perspective of a mediator, somebody who does conflict management, my idea, my goal is to try to get us to a win-win, try to get that relationship working in a way that you feel good about what you're able to do for patients and families, and they feel good about the kind of healthcare delivery they're experiencing. So I'm going to try to review that literature and then try to give us a new way forward by reframing how we see challenging patients and families. Because my belief is if we depict it differently, trying to get into the perspective of those patients and families, we can get to a more collaborative and constructive approach and interaction. And one of the ways that I'm going to do this is to introduce a concept called moral emotion, where I'm going to ask us to think differently about anger, which is often at the source of these tensions between providers and patients, to reframe and understand anger as having a particular type of function that has a good purpose. And when we think about anger in this more positive way, we can keep anger from escalating and getting into very maladaptive expressions and utilize it to craft a new way forward. Okay, so let's set the scene. The literature on how many patients and families are considered, most of that literature is on patients. So I combine them because for those of you who work with patients who are incompetent, who are unconscious, you're largely working with families, and a lot of conflicts at the bedside are with families and not just patients. But the empirical literature is really focused on patients themselves. And it describes a very wide range of how many patients are perceived by their providers as being challenging. 15 to 60% is almost a meaningless statistic because it's, from a very small problem to a overwhelming majority problem. But what you can see is that there certainly is a range, and in certain specialties, I would imagine one might find oneself on the lower end, and then in other specialties on the higher end. But the take home here is that managing challenging patients and families is a kind of an everyday problem. The literature, especially the early literature, that tried to get to the bottom of why patients or families are so difficult, focused on what's wrong with this patient. Why is this patient doing this? What's the patient pathology that generates these problematic interactions and dynamics? So the early literature sourced the problem in the patient. But as a mediator, I find that explanation to set us up for failure in trying to navigate these interactions that are so trying and enervating. The mediator believes that when you see behaviors that are labeled as difficult or very challenging, what you're seeing is the consequence, the response to a way that a patient or a family member is feeling or experiencing the clinical circumstance, the clinical experience. And that may be an interaction with a provider, but it might also be the interaction with the healthcare system and the kind of moments patients and families have that lead up to an interaction with a provider, a nurse, or a physician, but that have already set the patient on edge or have already created a high level of frustration. So mediators think about behaviors, not just about patients, just in general, that when they see behavior, they don't see behavior as the thing in itself. They see behavior as the outcome of something else, that it's a symptom that has a cause. And so when I think about challenging patients and families, I'm thinking about how the patient or the family has experienced something that from their perception seems wrong, seems inappropriate, seems negative in the delivery of care, which may not have anything to do in that series of events with the actual interaction with a provider, but the whole negative experience of healthcare up to that point has been negative. So from a mediator's perspective, we think of the source of the problem as being the patient or the family's perception of not being treated well by, who knows, by the receptionist, by the scheduling, maybe by the providers, by the system, who knows. So when you think about these two perceptions, one says there's something wrong with this person, and that's what's causing this. But in the mediator's perspective, the mediator says there's something being perceived by the patient as wrong. Something in this circumstance is wrong. And so it takes the explanation away from this person has a problem, is a problem, to what's happening from this person's perspective. What do they think is happening? And so from a mediator's perspective, people who are challenging are reacting to something. And what they're reacting to is a perception. And you notice that I've used the word perception multiple times. And that's because in interactions with human beings, perception is what matters. It's their belief that matters. It may be that everything has gone like clockwork, but that's not the patient's perception. The only thing that matters in trying to navigate forward is that perception and what you're going to do to respond to that perception or even correct that perception. So the difficult patient is someone, in quotes, is reacting to the perception of not being treated right or feeling wronged or feeling frustrated. And the solution then, from the perspective of a mediator, would be to get those mediation skills going, to try to understand those grievances and to try to address them. So before we get to that explanation, I'm going to try to argue by data that that is the case. Let me first acknowledge how big a problem for you these negative interactions are. They're not a small problem when you think about the quality of your clinical life and your well-being and even your ability to offer the highest level of clinical care. Nurses and physicians and others are constantly being barraged by bad patient. Now, of course, many times you get good behavior, but there's a constant stream of bad behavior that can be discourteous and impolite to maybe abusive and insulting to disrespectful interactions. And then heaven forbid, but we know it occurs, crossing over that line into physical violence. And the consequences to you are very serious, and you already know that, but the data also shows it. The kind of psychological distress, moral distress, and work burnout that providers feel is a very big problem and very real. So I just want to say at the outset that while I'm trying to give you tools to make this better, and I am going to be focused on the patient and family's perspective, I'm doing that in the service, yes, of helping families and patients feel better in their clinical interactions, but I'm also doing it because I believe it makes your clinical life better. It enhances your well-being to think in this direction and to do this kind of reframing, trying to solve a problem you face on a daily basis. Okay, so let's think about this early literature and this conventional view of what happens that makes patients and families seem so challenging. Well, the causal mechanism that is revealed in some of these early studies is that the patient or the family has a psychological problem. They have a character flaw. Either they have a literal psychiatric diagnosis, so they've got a personality disorder or, all kinds of, pathologies that could be psychiatrically diagnosed, or they have a moral problem. They're not good people. And so the hypothesis in that early literature was challenging patients and families are caused by some kind of moral or psychiatric disorder. But in the next wave of empirical literature, not only from bioethicists, but largely in the literature I'm going to show you from clinicians, there was a kind of pushback on that explanation had a kind of plausibility. I think it felt like it resonated with providers. But was it really true to what was happening in the conflict? Because what mediators believe is that conflict is between people. So any explanation that shows the locus of a problem being only one part of a dyad rather than what's happening between and among is inherently going to be, well, one-sided, but therefore hopelessly inaccurate or incomplete. So you see in the next wave pushback from the clinician literature. So from physicians who are pushing back in their studies on this early literature, which was also largely done by physician researchers. So here's some of that literature. And I'll just quote a couple of these pieces. But for example, this is a father and son, Gunderman and Gunderman, 2017. They argue that when you label someone as difficult, you're running the risk that you're not perceiving them correctly because the label itself is going to blind you from understanding, from their perspective, what's happening, which again, may not be the God's truth, but it's the perspective you need to navigate forward. or Elder Rice and Tobias, that maybe there's some things going on that are on the provider side. Is there something about how that patient is sparking certain kinds of attitudes or responses in the providers? Blackall and Green, who wrote the book Breaking the Cycle, talks about, are we getting blind spots here? In other words, are we not able to understand that other person's perspective that's leading us to respond negatively to their bad behavior with certain types of responses that intensify their bad behavior, so that blind spots leading to this escalation or digging in the conflict. And Strauss, Ullman, and Kotler, that maybe what we need to do is try to understand the perspective of the patient. And when I say all of this, I want to reiterate, I'm not excusing bad behavior. I'm not arguing that bad behavior is something that should be tolerated. I'm arguing that bad behavior gives you a palpable and clear sign that something's gone wrong, and that the solution to bad behavior is to look at what's gone wrong, which I'll illustrate with a case. So I want to reconceive the challenging patient in the service of making those interactions better. And to do that, I'm going to introduce you to Fred. Fred is a composite, but largely based on a case that I was asked to help navigate. So here is the case of Fred, and it's this case that I'm going to ask you to respond to in a moment with a prompt about analyzing this case. So that's where you're going to start writing in the chat. Here's Fred. Fred is a 16-year-old with an incomplete C4 injury to his spinal cord as the result of a gunshot wound. He's currently unable to move his arms or legs, though he does have sensation in his lower extremities. Before his injury, Fred attended school intermittently and was on probation for heroin possession. His mother is unable to visit during the week because of her work schedule, and his elderly grandmother is homebound. Since he has come to the rehab hospital, Fred has been verbally abusive to staff, frequently using sexist or homophobic slurs. His cursing, often loud, distresses the other patients, as well as the physicians and other staff. Fred often complains of pain and screams loudly when moved, though his physicians insist he's on the highest dose of narcotics that they feel comfortable prescribing. And because of Fred's language and derogatory comments, I'll go back. Both physicians and nurses are starting to refuse to work with him. Fred is going to be perceived as being difficult. But the question a mediator asks is, what makes Fred act this way? And the answer a mediator gives is not going to be allowed to be, Fred is a bad person, or Fred is a patient with a psychiatric diagnosis, that there's something psychologically wrong with Fred or morally wrong with Fred. That's the move the mediator will not make. Not because the mediator doesn't think it's true, they may not think it's true, but because it's not useful. It's not going to help to go in that direction. So they ask a different question, or certainly they ask the same question, what makes Fred act this way? But they're going to be looking for a different source to try to think through what the answer is. So the one thing we can see very clearly is Fred is angry. But that brings up this paper that I wrote called The 7 Maxims of Mediation. I didn't really call it that, but that's its nickname. And here they are. But maxim number 2 in the 7 maxims is this insight that we get from moral philosophy. Namely, anger is a reactive emotion. So the key is to find its source. Anger is responding to some stimulus. So a lot of times we glom on to the anger. We focus on the anger and we say, we won't tolerate anger and we won't tolerate the manifestations of anger. We can't have you be angry and acting in ways that display your anger. But a mediator is going to say, not Stop being angry and stop reacting in ways that display your anger, like calling somebody names. That's what medicine now does. And they've got signs on the walls that say you must act in a civil way. That's to focus on anger as the thing in itself. But a mediator is going to say, what's the source of the anger? And they're going to try to address the problem at its source. Because if we can solve the problem at its source, the person won't be angry and they won't be manifesting those consequences and behaviors that display anger. Okay, so now this is where you're going to come in. Let's revisit the case, but now not from the perspective of the physicians and the nurses, but let's try to get into the mind of Fred. And let's try to think about what is making Fred so angry. But now the first kinds of answers you might give, which we're going to hold off yet, don't start with the chat yet. The first kind of answers people would give naturally in a circumstance like this is that Fred is angry. Let's go back a second. That Fred is angry at God. He's angry at the shooter. He's angry at fate. He's angry at his condition. And who would doubt it? When we get the short straw, when we are handed such a terrible hand like he has been dealt, we are angry because it is unfair. And those are the kind of words that we use. But a mediator wants to ask a different question. What's Fred's perspective about how he's being treated in this unit? What's his perception of how the staff view him? What's his perception of the way that he thinks he's being treated? Because there's no doubt that there's going to be some anger, and that's probably going to be intensifying whatever else is going on with Fred, because to be dealt a hand like this makes one so enraged with the injustice of it. So it's going to play in to one's reaction to any other stimulus. But what I want to ask you to think about is, does Fred believe that the physicians and nurses in this unit are treating him well? How do you think he's being treated? How do you think he would describe the way they treat him? And again, before you start typing, I'm not suggesting that that is how the nurses and physicians are treating him, because in mediation theory, what we're trying to get to is, how does he perceive that he's being treated? So now I want you to write into the chat the answer to one very narrow question. How do you think he thinks they think of him? What judgments, what assessments does Fred perceive on that unit? How does he think they're treating him? And how does he think his treatment by them is going? What's his perception of how the staff treat him, given what we learned about in this case? And while you're writing, and I hope you're writing, let me say one other thing. When in clinical ethics, you get a case description from someone else, they are authoring it. They are writing this case. And what that means is they are selecting certain elements that they're putting into this case, and they're leaving other things out because that's what authors do, right? They have to. This is written by someone. So someone intentionally wrote certain features of what's going on here and left other things out. So when you think about what has been written here about Fred, how do you think that plays out on the unit? All right, give me
some of the responses are here. He may feel he's not respected and not heard. He is in pain and his treatment has not changed, so he feels ignored. He's an addict, might also be tolerant to opiates. He thinks that they're not giving him enough pain medication and ignoring him. So that seems to be a thread here of a lot of the comments. He feels no one is helping him. He's been through a lot, so he's perceived as angry. He thinks that they label him as a bad kid, a truant, drug-using, possible gang member. And certainly, I guess the other question is how perceptive he can be if you try to investigate that further. But
okay, so you all have done a magnificent job. And when I see such insight in an audience, you are primed to be able to work with patients and families in a constructive way, because you are really putting yourself in his position, and everything you said seems very plausible to me. And when you think, in addition to all the things you said, and again, this is about perception, and then that's one of the comments you've made, Dr. Sidebottom, that this is perception, so he may not be in a great position to have an accurate perception. You're absolutely right. And the thing is, we have to deal with the perceptions people have. And just adding to that, I mean, I love the comment about how he's a bad kid. I mean, think about why the clinical staff was told that he attended school intermittently, or that he was on probation for heroin. I mean, he might have taken the heroin, but he might just have been a dealer of heroin and not even have been an addict. The idea that was a truant. The idea, I mean, of course, part of the clinical picture is that he was shot, that it was a gunshot wound. But I hear from audiences many times that, oh, he was in a gang, or this was a gang or drug related, when we have no evidence for that. All of that adds up to the insights you've given me, which is, I don't think he thinks he's being treated very well in this clinical setting, which doesn't mean they're not trying hard, but it means the problem we have to solve isn't the secondary problem is that he's using sexist and homophobic slurs, and he's yelling and he's screaming and he's, being abusive. That's the thing that ultimately you all want solved. But the way we're going to solve it is to get to the source of why he's doing that. And you've given some good reasons here. The non-mediator hypothesis says Fred is angry because of God, shooter, and fate. But the mediator says, yeah, but you know what? That lets us direct all of our attention to things that we can't do anything about. And it kind of lets us off the hook. I don't mean guilt-wise. I mean in terms of being able to do something. What can you do about fate, the shooter, and God? Nothing. But you can do something about having Fred not feel ignored. You said that. You said he doesn't feel listened to. That's something you can do something about. He doesn't feel validated. He doesn't feel listened to. That's something we can do. And if we can achieve him feeling less ignored, feeling like people are trying to address his pain, feeling like he is respected, wow, we can change this game in a very radical way. And that will stop him, without even talking about you shouldn't use these slurs. It'll stop him from making the slurs, because he's making the slurs because of these things that he's perceiving.
Another angle that one respondent said is Fred feels like he has no control. And in terms
Yes.
of an action, another respondent said, "Is it okay to ask him what's bothering him?" So that sounds like
Of course, these are the exact interventions you're going to do. And let's take a look at that idea of control. It's so interesting that you say that, and you're so right. In this actual case, Fred's physical therapy time slot was 7 a.m., and he didn't like that. And I said, as the first move, is there any senior citizen who's already been up since 4 that could take the 7 a.m. slot? What teenager wants to do physical therapy at 7 a.m.? He had no control over anything. Not only is he a quadriplegic, he doesn't even get to control when he goes to physical therapy. Is it really the case that that's the only open slot? I bet not. So what kind of control could be put back into Fred's hands? So when we think about Fred and his experience on a daily basis, we ask, does he feel patronized, dismissed, demeaned, humiliated, stereotyped? Does he feel those things? Not because it's true that the inpatient unit is doing this, but because if he thinks that those things are happening, it's what has to be addressed. Does he feel powerless and emasculated from just the injury, or is the way that they're going about the treatment of his body, is it feeling emasculating and powerless? Is he feeling powerless? I mean, you think about a body that can't do anything for itself at the same moment when someone is entering just burgeoning manhood and sexual development. It wouldn't take much for somebody to feel humiliated. You've already said you're worried he doesn't think he's respected and heard. Does he think that they are treating him as well as the skiing accident in the bed next to him? Does he think that it's the fact that he has a gunshot wound is already coloring the way they see him, and that they have already deemed him a loser or a bad kid, you said, from the minute they walked in the room? It may not be true, but does he think it's true? Does he think that he's been branded drug seeking, gang member, high school dropout, junkie. Does he think this staff cares about him? And do they? And if they don't, yeah, I can imagine, because people, day after day of dealing with this, it's like what you want to just do is say, okay, I am divesting here. But people pick that up. So we got to break that cycle somehow. If Fred feels mistreated or misunderstood or wronged, he's not just angry at God, the shooter of fate. And so we have a concept to capture this idea, and it's called the moral emotions. So in philosophy, a moral emotion is a type of emotional response that functions as a radar detector. And think about in your own life how sometimes you have flared up with the emotion of anger, but you haven't yet tracked what's made you so angry, because your emotional response flares first, and then your cognition analyzes what made me angry, what was the affront, what was the wrongdoing, what was the slight, the threat, the harm, because anger is one of the emotional responses that has a very important purpose in human life. It's to protect our personhood. And that protection can be physical, like when somebody cuts you off on your morning commute. In Massachusetts, certainly around Boston, like a daily event. I lived in Boston for 4 years. It could also be to your integrity, your self-esteem. It could be what you think you're owed, what is due to you in terms of human respect. Any of those indicators, I'm not being treated properly, will have someone feel the moral emotions. And there's 3 classic moral emotions: anger, which is what we're talking about here; resentment, which is a long-standing, ongoing affront to something, your personhood, your integrity, your reputation, basic respect; indignation. How could you do this? How is it possible? All of those 3 are moral emotions, part of our protective radar system to protect ourselves. And when you think about it in that light, you don't focus on the consequence, on the expressions of a moral emotion. Instead, you try to understand what's sourcing those moral emotions. So people who feel those emotions in that moment, indignation, resentment, and anger, they are very prone, all of us are prone to expressing that grievance in counterproductive and maladaptive ways. Some of us have more safeguards and safety valves than others. Some of us are able to muster up decorum in the context of those emotions when we're doing well, but not when things are going awry, that when someone is pushed. I think about I gave a podcast on the challenging patient, and this pediatrician said, I'm very easygoing typically, but when I didn't think my wife was getting the care I thought she needed in labor and delivery, I found myself to be a completely different animal in terms of what that anger was sparking in me and how I was reacting in that clinical context. And I give that example only to say that some of you are able to just be polite and decorous in all circumstances. And some of you are hot-tempered like me, and it doesn't take much to spark that match. But we're on a continuum. And so when people feel those moral emotions, especially when they're not well, especially when they're frightened or grieving or feeling despair or terror even, many of us can go counterproductive. Many of us can go maladaptive. And so this move in clinical medicine to try to, and for good motives, to protect all of you and the integrity of clinical care. But when medicine now focuses on those counterproductive and maladaptive reactions, they're missing the source and focused on the symptoms. So they've got they're ignoring cause and looking at effect. Well, all you're going to be able to do with effect is clamp down on reactions. You're not really going to be able to solve the problem. And to clamp down like that with signs that say, be civil, or I will talk to you only when you calm down, or I'm canceling your appointment and you can reschedule, any of those maneuvers can coerce, or I won't treat you if you don't stop talking this way or behaving this way, or giving a behavior contract that says you will comport yourself nicely or you cannot be here any longer. Any of those things are well intended to try to achieve this noble goal, but all they do is try to encapsulate or clamp down on what is still going to be there. And so it is highly likely that source material, the causation, is going to break through any of those mechanisms that are designed to tamp it down and contain it from the mediator perspective. So my claim is, if you have somebody who's a challenging patient and family and they are reacting inappropriately, because I'm sure they are, it is inappropriate, it is counterproductive and maladaptive and insulting and abusive, no dispute there, then I want you to think about whether one of their interests is being thwarted or negated or dismissed or ignored. And how can we then address their interest? So how do we address Fred's concerns? If the challenging patient is someone who feels a moral grievance, then our obligation is to think about, what is that grievance? Fred, I don't know if we're literally saying, Fred, you don't feel heard, but if we believe, hey, Fred might not feel like he's being heard, then our response is to say, how do we make him feel heard? What can be done to address Fred's concerns? And some of them are very concrete, like, do you really need to force him to go to physical therapy at 7 a.m.? Some of them are about perception. Fred believes you're not doing right by him on pain relief, but I'm sure you are. I'm sure you're trying. How do you get through the perception that he's not getting the kind of pain relief he needs because you stereotyped him? What do we do to address those concerns? How do we make him feel like he matters to us? And then sometimes audiences say, but wait, he was already behaving badly before we had any opportunity to not treat him well. So let's assume that he really did fire off with these insults and abusive language from the minute he was transferred from the acute care hospital to the rehab. They didn't have time to not do well. He's already firing. Well, then the mediator says, okay, but what reactions did you give him when he got there? Fred, I see a lot of anger. Let's think about what's happening here and what we can do. Were there any stereotypes that were employed to glom on to the interpretation that this is a bad guy? What kind of support did they offer him? His mother has to work. She's got to put food on that table, and she's also got to take care of her elderly mother. So what kind of support system can we offer? What do we have here? Do we have clergy? Do we have group therapy? Do we have therapists? Do we have psychiatrists? What do we have here to offer support? Do we have certain types of nursing care that specializes in this kind of support? Were his needs addressed, and was he reassured, you're going to be okay here? We're here for you. We're going to make sure that we do right by you. And did people employ trauma-informed care principles? Medicine so rightly now talks about trauma-informed care as this such an important idea that patients are bringing their trauma. But people who are bringing their trauma are often not pleasant. So on the one hand, we worry about trauma-informed care, and on the other hand, we malign and criticize patients who are bringing that trauma and exhibiting that trauma because it's not fun, it's not nice or comfortable to witness. But it's the same idea. When somebody's bringing that kind, this person surely is bringing trauma. What are we supposed to do in the face of that? Well, what we're not supposed to do is condemn. So how do we use trauma-informed principles to manage the very challenging interactions we're going to get when people have been and are currently being traumatized? But you might say, wait, maybe these patients really do have a psychiatric disorder. So let's say Fred has a psychiatric disorder. Well, the thing is, what I'm saying to you today is backed up by psychiatrists. A lot of this literature that I'm talking about that motivates me comes from the conflict management literature, but it is mirrored in the psychiatric literature. Some of the best material out there in terms of de-escalation and conflict management are coming from the psychiatric discipline. So they are dealing with psychiatric diagnoses and they're using these techniques. So if he has a psychiatric disorder, you still need to do these kind of approaches to try to manage the challenging patient or family. And I believe we owe patients that because challenging patients think that they're being wronged. And if that's true, then we have to address and validate and repair and assist, even if they think that there's something happening that really isn't. Because we don't want to be the people who are making another person feel wronged, even if it's a misunderstanding or a misperception. So where have we gotten to as we enter our question and answer phase or objection phase? There's a prevalent view. Where have we come this morning? There's a prevalent view that the challenging patient has a problem, and it's their problem. It's a patient pathology problem. But mediators believe that those kind of behaviors are part of an encounter, a dynamic, perceptions between and among, and the solution has to be between and among. So rather than patient pathology saying, what's wrong with this guy? We say, what's going wrong for this guy? And we try to respond to those grievances. Difficult patients, challenging patients feel affronted. They feel wrong. They feel shortchanged. They've got the short end of the stick. We need to understand those grievances. And we need to focus our attention on the cause, not the effect, if we really want to solve these problems. Oops. All right, your turn.
Well, certainly, the other question or the observation that came up was, would a psychiatry consult be equal to a mediator consult? And in some respects, practically speaking, maybe we don't have access to a mediator in the healthcare setting. So that may be our only option. I mean, even if you recognize and approach things from the patient standpoint. So any comments about that?
Yeah, I think that there are, depending on your institution, there are certain types of disciplines you could go to. Psychiatry would be one of the places that you would look, especially if you've got a psychiatric staff that has the time to devote, so that they really do have that kind of ability to do extended conversations with patients. And so that puts them in an available category, not just come in, ask a couple of questions, but do they have the time in the way that their workload is divvied up? Then I think psychiatry is a good choice. You also might have social workers that might be able to play some of these roles. You might have clergy who might be able to do some of this work. You might have clinical ethicists that might be able to be on board. And for patients who are needing pain management, you might be able to get the pain management palliative care folks in because they also have certain kinds of skills. So I think you look at your institution and you think, where are the resources? Because the person you don't have is the person called mediator. But many of these people have mediation training. And another thing that you can think about doing is getting some of these individuals from these various disciplinary backgrounds and nursing. Let me not neglect nursing. I edited a journal. The journal is called the Journal of Narrative Inquiry, but they did a special issue called Managing the Difficult Patient. And it's a very interesting journal. They go to people on the ground, so practitioners, and they ask them to write first-person narratives. So everyone, what this is a collection of stories from physicians, nurses, and social workers about an experience they had trying to work with a challenging patient. And I was the editor of this journal, of this volume, and I wrote a paper gleaning insights from physicians, nurses, and social workers for how they managed these particular patients. And one of the things that came out of this article was how much relationship building some of these particularly these different providers, social workers, nurses primarily, but sometimes physicians as well, how much investment they were able to make in those relationships. So another neglected category might be nursing, because they tend to have more face time with patients who are in an inpatient unit, and you might be able to identify certain nurses who have really strong skills in relationship building. But another thing you could do is get some of these point people trained in actual conflict management skills. So there's online training, we do in-person training, there's Cornell has an online program, Harvard has an online program, where you might pick a few people who have a lot of clinic time. Maybe it's clergy, maybe it's someone from nursing, psychiatry, to get these more advanced clinical management skills so that they could be the point people in your various institutions.
No, it's a very, very practical approach. It reminds me of advice I was given a long time ago um, about what's the first thing you do when you're called to a code. You check your own pulse. So making sure people check out their own
Right.
mind frame of how they're looking at things, as well as appreciating the patient.
And that's such an important point. Let me just add to that. Mediators are like Teflon. They get on the neutrality that's in that 7 Maxims paper. They get to that place of zen and peace. And while stuff is being spewing at them, it's just bouncing off. It's not getting in. It's not corrosive, and it's not enervating. That's one of the things that mediation training can teach people. Just like when you go to a code, you have to keep your own heart from racing, and you got to stay calm. When you encounter someone spewing like that, you have to stay calm. You've got to be saying to yourself, this is not about me. This is about the dynamic. This is about something going wrong. I am an instrument in the solution to this problem, just like the person managing a code is an instrument to try to see what to do with somebody who's arresting. That's what a mediator does, and that training can help. But even if you're not doing that training, it's imperative that you say to yourself, I'm not going to let myself get angry about this, because whatever's going on, I'm the solution here. I'm bringing the solution. I can't be a partisan to this problem.
Right. No, and I full well recognize that from my original background in pediatrics, when we had a lot of problems with child abuse, and you recognize that, and it was just so important to check your anger at the door. Otherwise, you will be part of the problem. So
Right. And then you're really locked in and escalating.
right. I remind people also, please click on the link in the chat box to review the program and to qualify for credit. Can you offer some phrases or examples of effective communication with difficult patients?
Uh,
Or is it individual of each case, I guess?
no, it is, but
Maybe some
the
generic.
idea. So one of the ideas is to paraphrase what that person is saying, not parrot, which would be mimicking, and people hate that, but paraphrasing the content, the guts, the substantive juice of what they're saying, stripped off of ugliness. So think about how if you have got a diamond, that what the speaker, the person, the patient, the family, they're offering you a diamond of information of what matters to them. Yes, it's cloaked in smelly smoke, but you're going to laser lock on the diamond, focus on the substantive content of what they're saying. So if they're ranting, they're actually delivering a diamond, but it's in a form that is offensive and ugly. Laser lock on what they're saying and repeat back to them what they've said. So if they're saying, this hospital is trying to kill my freaking father, then you say, it sounds like you're worried that your father is not getting the kind of care that would be safe and actually curative or care that would be good for him, but instead they're working against what you think he needs, and that actually maybe you even feel that the treatment is destructive or is harmful. So I took one phrase, I tried to get to what is this person saying with this phrase, and I tried to say it back. And then we'll see if that person thinks, yeah, That is what I'm worried about, because now you have taken ugly form with a diamond content and repeated it back with diamond content with no ugliness. You have stripped off the ugliness, laser locked on the content, delivered the content back stripped of the ugliness, and now you can just talk about content and not swear words and insults. Now you can talk content to content. So that would be the biggest thing I would say, is that you want to focus intensely, especially if your heart is racing, your back is up. What is this person saying? What is the meaning of what they're saying? What are they trying to tell me? And repeat it back. Because the more you repeat back, and don't try to be a genius. Hey, I'm going to summarize your 10 sentences in one sentence. What you're trying to do is use your words to articulate all the aspects and nuances of what they said. So don't shortchange. If they said 10 sentences, give them 5, 6, 7 sentences back that dig for the meaning, because hearing your own concerns mirrored back to you is soothing and reassuring and validating.
Sure, it's just like, I mean, just classic psychotherapy. And sometimes expressing it to somebody else
That's right.
allows you to see it more
That's
clearly.
right.
Yeah,
That's
yeah,
Carl Rogers, right out of the 50s in active
yeah.
listening and psychotherapy. That's right. And
Again,
that's
to
how it
remind
works.
people, please click on the link in the chat box to review the program and receive credit as well. And Karen had mentioned that the possibility, at least in our own institution, whether our spiritual care department
Yeah.
might offer information.
Yeah, I
regarding
mentioned
this.
that. Clergy. Yeah, I should call them
Yep.
spiritual care. That's your word.
Right, right.
Absolutely. And they have in their training, they often have some of these self-reflective exercises that they do to think about, okay, what's my belief? What's this other person's belief? How do I understand somebody else's spiritual life and not have it clouded with my own? They have a lot of that baseline training, and they're not in the clinical context. So they've got a kind of distance. And getting those individuals mediation training to be on top, we've trained lots of clergy. It's very helpful. And they're also on site
Sure. Yeah,
or
and like you
available.
mentioned, the other, many other disciplines within the healthcare environment. It does not have to. It could be a physician. It could be a nurse,
Right.
as well as, like you say, clergy and stuff. So,
Right. Social
that,
workers, don't neglect them. They
yes,
are
right,
assigned
exactly.
to talk to patients, right?
Yeah, yeah, yeah. No, it's
Yeah,
very helpful. And I think again, the tenet that's key to what you're mentioning is, put yourself in the other person's shoes. I mean,
yeah,
you want to patronize them, but
right,
again, like you say, trying to express and reformulate what they're expressing and making sure that you have the tenets of the portions of that correct. And if you're not hearing it correctly and expressing it correctly, allow them the space
right. Yeah, they'll
to
correct you.
correct you.
Yeah, exactly. They'll say, no, that's not quite it. What I meant was.
Right.
But what they'll do in your summary is credit you with trying.
Hmm. Exactly. Yeah. So good. No, I see, there's some great comments here, but I do not see any other questions at the moment.
Okay.
It's very instructive in terms of what you've had to say, and very practical with respect to an approach. And again, having people recognize where they're coming from for sure. I apologize. Karen has tried to correct, and I don't know if it was something on your end or not. There's been some big black boxes that have shown up, at least on our end, in some of your slides. Unfortunately, I'm not sure exactly why. You tried to correct that. I apologize.
No.
But we're able to see the bulk of what was going on. And then another respondent here said, what about having input with family members? Sometimes that can be good, sometimes it can be bad.
Yeah, no, I mean, definitely if they're allies, but and the more sophisticated the facilitator, the more people you can manage at once. But yes, you can definitely, enlist their help. I just want to point out that I've given you my email address. I have open office hours every morning of the week, 7 days a week, 7 a.m. to 9:30. That's my cell phone. People can call if you have any follow-up questions or you need advice or you want whatever. That's the number to call, 7 a.m. to 9:30. In fact, while I was talking, I had some calls that I'll make now back for my morning office hours. That's my email address at Penn if you'd like some of the papers or you have follow-up questions, or if anybody's ever interested in training. We do it 4 times a year at Penn. It's a really wonderful group. So, and it was
Sure.
great being here.
No,
Thank
that's
you.
great. Well, thank you very much. You mentioned about being more of a fiery person. I find that hard to believe in terms of the content in your presentation, but
Oh,
you know.
Don't get me mad. I'm like a gremlin.
So again, click on the link in the chat box for credit and a review of the program, and we'll look forward to having a review once again. It was a wonderful program. Thank you very
Thank you
much.
so much, everybody. All right, have a great day.
Take care.
Take care. Bye-bye.